Hi everyone, welcome. I'm Angela Love-Zaranka with Lactation Education Resources. Sekeita?
And I'm Sekeita Lewis-Johnson, also with Lactation Education Resources. Good morning, good evening, and good afternoon.
So we're here today to do some last minute exam prep. Sekeita and I together have over 50 years of experience supporting families both in the community and a hospital setting. And so without further ado, we would like to dive into this topic. So how to ask questions if you're participating today on a desktop or a laptop computer. You'll see the question box here. Notice as indicated by that blue arrow, it's there in the subject panel, and so you can ask questions there. You can also type in comments, and so we'd love to know where you are participating or listening from today, and so please do practice with the question box and go ahead and type in where you are located. Or if you are on a mobile device, then you will see the question box here at the bottom. And so if you notice the green arrow there, so you'll see that question box. And so please do ask questions if you have or comment. And we are actually going to have an opportunity for a poll shortly. And so we're going to do some sample questions. And so you'll be able to mark and reply when the poll is activated. It's not activated yet, but when it is activated, you'll be able to see it. We have a wonderful support team here today. We have all three of our customer support people with us. I think that's a first. And so Julie and Kim and Wendy are on the call. And so if you have any questions, feel free to ask in the chat and they will answer them for you, and they will flag questions so that we can answer at the end. If you're having any tech issues, we have Jill on the call as well. And so please do ask any questions that you have or make any comments, and we're more than happy to address them. Okay, great. So without further ado, one more quick comment about ground rules. Please do not record or take any screenshots of this information with a phone or a camera or any other equipment. We are recording it, and you will be able to review this session as many times as you need to. Now, a few of the questions which will be answered by our customer support team, they are very well versed in what it means to be an IBCLC and taking that test. We actually have other IBCLCs who are on the call as well. So they recently sat the exam. They're happy to answer any questions that you have. And then at the end, Sekeita and I will address questions for everyone. Great. So now we're going to get started with these key concepts, a few key concepts. And the first one is medications. Sekeita?
Yes. So I want to start off by stating we're starting with a topic, medications. A lot of people are like, oh, this part is overwhelming. It's not going to be as overwhelming as you might consider, but we're going to start with just some key points to remember and some key points to keep in the forefront of your mind if you are presented with a medication question. So let's dive in. So again, it's important to remember that the amount of medication of drugs that's excreted into milk, it depends on many factors. So let's review some of those factors. So initially we're going to talk about the milk to plasma ratio. So when we think about milk, we think about, okay, we know what the milk is. Plasma is blood compartment. And so thinking about the milk to plasma ratio, it's useful to evaluate the concentration of medication in the plasma compared to in the milk. That's what that means. The other factor to look at is the relative infant dose. Now, this is a very important clinical parameter to determine safety. It's usually expressed as a percentage, and it's a percentage of the maternal dose. According to Hale, and Hale has a book, when I say Hale's, what I mean is Hale's Medication in Mother's Milk. That is an awesome resource. If you have that resource, that's a great resource to kind of follow along with, so you'll see every single drug that's listed will have a milk to plasma ratio. It'll have the relative infant dose. It'll have the molecular weight size, some of the things that we're going to talk about. But anyways, according to HELD, medications with a relative infant dose that's less than 10% is considered relatively safe for a full-term infant. And I want to preface that part, full-term infant, because we know that with full-term infants, full-term means that pretty much they've developed how they needed to develop. Preterm means that there's still some growth and development that needs to take place. And so that's why these medications are for full-term infant. That's why the definition is really for full-term infants. So a relative infant dose that's greater than 10% for a full-term infant should be a cause for caution and further assessment of the situation. So what this is saying is it doesn't mean that if it's over 10%, it's a no. It just means that we need to look at other things, which leads me to oral bioavailability. This concept refers to the ability of a drug to reach the circulation after it's been ingested. So drugs with a low or not only ingested, but maybe in the IV or maybe as a injection. So just keep those in mind. But after the oral bioavailability is for oral only. I'm getting ahead of myself. So drugs with low oral bioavailability are generally poorly absorbed in the GI's tract of an infant. And they are destroyed in the gut. Are destroyed in the gut or taken up by the liver prior to entering the infant's circulatory system. Let me repeat that because I know I just jumbled that up. Oral bioavailability refers to the ability of a drug to reach the circulation after it's been ingested. Drugs with low oral bioavailability are generally poorly absorbed in the infant's GI tract and are destroyed in the gut, or they're taken up by the liver prior to entering the infant's circulatory system. So with that being said, you want to keep in mind that medications that enter the milk compartment can only come from the lactating person's plasma or blood, okay? Remember that during the colostrum phase, this is another key point to remember. During the colostrum phase, medications transfer into milk easier because what we call the junctions are kind of spaced out. Once the lactogenesis begin, the junctions tighten, and then there's less opportunity for milk to get in. For drugs to get in. So medications transfer into the milk easier. However, the total dose transferred to the infant is low due to the limited milk volumes. Remember, colostrum is limited in its volume. So medications transfer into the milk easier during the colostrum phase, but it's limited due to the small milk volume. So I just said most drugs will enter at a clinically insignificant level. That's a great point to really understand when we're thinking about risk benefits. The most important things is determine the levels in the milk, the relative infant dose, and the lactation risk category. As we think about lactation risk category, I mentioned HELD's booklet. In HELD's booklet, HELD, stratifies, I'm going to use the word stratifies or categorize the drugs based on an L1, which is the safest, all the way through L5, which is hazardous. So you want to keep those in mind. A lot of times people think that vitamins are just not a big deal, but you want to be cautious with high vitamin doses because they can be a problem, a source of problems. The other thing is there are certain key medications that we have to avoid. high doses of medications that are sedative, opioid, narcotics, opiate, narcotics, and these are high doses, radioactive agents, anti-cancer drugs, and high doses of iodine. When we think about opiates, we know that opiates are prescribed sometimes post-birth. Keep in mind, we say high doses, or sometimes we'll say abuse or misuse of opiates. So those are things to keep in mind. So standard doses that are generally prescribed, most providers prescribe things that are generally safe for lactation post-birth. So I'm going to keep talking about this one key thing about how milk is transferred. So remember that drugs may transfer into the milk if high concentrations are in the lactating parent's plasma. So those drugs that have low molecular weights, that are, for instance, less than 800 Daltons, will pass easier than a medication with high molecular weights. The other thing to keep in mind is medications with low protein binding, and those will pass, and medications that pass easily into the brain, those are also things that we take into consideration when we are thinking about medication safety. And the point about passing easier in the brain, remember I talked about development and preterm and full term. Those are some other considerations that we have to start to think about when we think about medications. Now, the good thing is the exam should be really geared toward the novice person, but in practice, you may have already, or if you were following someone clinically, you already may have an idea of some of the special considerations that we have to take into account when we're really working with preterm infants. So it's always safe to check your resources and to choose medications with short half-lives, high protein binding, and low oral bioavailability, and or high molecular weights. So pay attention to that last bullet point. Those are what you want to really are the preferred drugs that really are safer. So antibiotics. Antibiotics are commonly prescribed during pregnancy, also during lactation, which most don't pose a problem. However, a lot of people sometimes will still question, are they safe for breastfeeding? So as a rule of thumb, antibiotics are safe to take. However, Cipro is one that is an L3, and it's associated with GI problems. So with that particular medication, you may want to, and when I say GI problems, I mean GI problems for the infant. So you may want to, discuss, if you're a lactation supporter, have your client discuss, or the question, discuss with the provider whether there's a safe alternative. So what else was I going to say about that? Oh, I know what I was going to say. The other part about antibiotics is that, sometimes antibiotics can be associated with the development of thrush or a yeast infection. And so in the next slide, I am going to go over antifungals and some treatments for those that are safe for yeast that is safe. But if you're not familiar with the names of many drugs, it might be helpful to know that most antibiotics end in CIN, such as, like if you look at this, you'll see ampicillin, amoxicillin. You'll notice that cephalosporin is not, clindamycin is not, azithromycin. So you'll look at this and say, okay, there's mycin. There's levofloxacin. So if you look at the SINs, you will see that most antibiotics end but not all. So just be mindful. But you also look at the categories. Look at the categories. And I listed the categories on the right side as L1, L1, L2. Then you get to some L3s. There's another L1. And again, you can refer to HEL's medications. So antifungals, I talked about antifungals. These drugs are most commonly used for thrush or yeast. Thrush is an oral infection. If a baby is diagnosed with thrush, then both the infant and the lactating parent should be treated simultaneously. As that thrush is theorized that it can pass back and forth between them easily. And thrush is one of those things that there's been some controversy behind it, but just know that as of right now, if a baby is treated for thrush, so too should the parent. Topical antifungals such as nystatin or miconazole are used to treat yeast and are considered safe as long as minimal amounts are applied to limit the oral absorption by the infant, so in small doses. Clotrim, I always have, can't get this word out, but let's try it. Clotrimazole has been implicated in contact dermatitis and should be avoided if possible. However, HEL does have it listed as an L2. All right, so moving on to pain management, analgesics. We talked about how it's common for antibiotics. There's also common for pain medicine to be given post-birth. And one of the things to notice is that certain medications are safe for pain management, and some that we previously thought were safe are no longer considered safe. So for instance, Tylenol 3. If you look at this, Tylenol 3 is composed of acetaminophen, and it's also composed of codeine. So if you look at the right of the screen, acetaminophen is what? An L1, which is categorized as safe, generally safe. And the codeine is L4, which is really can be possibly hazardous. That's what L4 is. So there are a few people, because of they found this out, and this has been in the last, I would say, few years, where they're like, no, Tylenol 3. The FDA came out and said it's not really a drug that should be given, because there are a few people with a genetic trait that make them very rapid metabolizers of codeine. And so along with the FDA, there's been other advisory groups that recommend that codeine should no longer be used in lactation. So you think about Motrin, you see how there is an alternative, Norco, which is it contains acetaminophen and hydrocodone, which is an L3. Motrin is considered relatively safe, it's an L1. And then you have aspirin, which is an L2, but again, you want to avoid this medication at high doses in lactation when an infant has a viral infection. Let me just make sure that I am not missing anything. Yes, I did miss something. So aspirin, like I said, is considered a low risk medication. However, aspirin has been associated with Reye's syndrome in infants. And so that's why you want to avoid it if the infant is sick or has a fever. All right. Any narcotics that are used, such as Dilaudid, hydrocodone, should all only be used for short periods of time. And babies should be monitored for sleepiness or poor feeding. Those are the concerns when it comes to certain narcotic medications or opiates. All righty. Anticonvulsants, anti-seizure medications. A lot of times I've seen in practice, people will say, oh, I have to go on my seizure medication. This is not safe. And sometimes people think it's because, okay, seizure medications impact the CNS, which is the brain, the central nervous system. What you want to keep in mind is that these seizure medications are relatively safe. With the exception of Depakote. If you look at Depakote, it is an L4. And so it warrants further investigation. It warrants further risk benefit. It warrants collaboration. It warrants a lot of things. The very last medication listed on this slide is magnesium sulfate. And really, it's used to treat preeclampsia. So this is one you might hear often. Magnesium sulfate is not contraindicated with lactation. It is an L1. But again, because these medications impact the central nervous system, you want to be cautious and mindful that some of the infant concerns can be sleepiness, poor feeding, and even irritability. Antidepressants, there's been lots of back and forth information about antidepressants, but what I will say is these 3 antidepressants that appear on this slide appear to be safe for breastfeeding and lactating parents who are experiencing various levels of postpartum depression. It is truly certainly better for someone to be taking an L2 medication than to be depressed. However, again, on the far right, you'll see some of the concerns: sleepiness, poor feeding, low muscle tone. Some babies may have agitation, and then withdrawal symptoms may be noted if they were exposed during pregnancy. Which means that if the person was taking the medication while they were pregnant. So paroxetine, sertraline, and fluoxetine, and you'll see there the drug name. You'll also see what their most common drug name is, but you'll see they're all in L2 category. Antihypertensives. Antihypertensives are for people who have high blood pressure. So the anti is to really bring the blood pressures down or regulate or manage the blood pressure. There are all different types of antihypertensives that comes in different drug categories. So what I will say about antihypertensives are really pay attention to the lactation category, as well as making sure that if the client is on antihypertensive, again, and you'll see some of the same infant monitoring. So when you think about infant concerns, it's always going to be either sleepiness, lethargy, poor feeding, even pallor can happen. And the bottom category, and remember I said there's different classes. The last hydrochlorothiazide and furosemide, those are what we call, they are diuretics. And those are medications that can control blood pressure, and they can also get excess fluid off of people who have had, like for instance, if they've had so much fluid during their labor. Those are medications that have the potential to reduce milk supply. So those are medications that a person should not be on long term. It should be something that's treated in an acute situation, but not something that's taken every day, because it will impact it has the potential to impact the milk supply, which is reduce the milk supply. Generally speaking, vaccines are safe while breastfeeding and lactating. However, the yellow fever vaccine is not recommended at all. Now, excuse me, when you think about the smallpox vaccine, I want to read this excerpt, and it's from Lawrence and Lawrence, and it talks about what the concern is as it relates to smallpox. So smallpox vaccination is inadvisable for the mother or an infant younger than 1 year of age, nursing or not. The personal contact, not the breastfeeding, causes the risk. Therefore, no advantage exists to weaning if vaccination is necessary. This vaccination is not given routinely and is rarely indicated. So there's that. So I wanted to read that excerpt because there was a question about it the last time we did this. And it's important to know that sometimes it's a contact issue and not necessarily a milk issue. And so that's the other key point that you want to always take into consideration when you're thinking about any medication whatsoever or any even disease process. So with that being said, I'm going to turn it back to Angela. And if you have any questions, because I know that there was some rough parts with me this morning, please put them in the chat and I'll do my best to answer you as best as I can. Angela, take it away.
Thanks, Sekeita. All right, so going to the next slide here. Now we're going to talk about breastfeeding beyond the first month. This topic, we have this topic actually in our exam review for breastfeeding beyond the first month. So some of this information may be a wee bit familiar. You can, if you'd like more information, you can refer to the corresponding courses from our lactation consultant training program if you took that, or in the infant growth and development and breastfeeding the older baby and weaning lectures in our exam review. So when counseling clients with older nurslings, be mindful that the number of feedings and the time at breast may fluctuate greatly. Babies might return to intense breastfeeding to adjust their parents' milk production as needed, which is sometimes referred as growth spurts. They often occur around 2 to 3 weeks, 6 weeks, and 3 to 4 months. This coincidentally corresponds with a shift in maternal hormones with the gradual transition of endocrine to autocrine control of milk production. Developmental milestones may increase night waking and nursing. These little ones have been so busy exploring their world during the day that they didn't spend much time at the breast. They're too concerned that they're going to miss something. Therefore, they may wake more frequently at night to receive the caloric intake they intrinsically know they need. Latch-up positioning technique is considered considerably more flexible after the first few months. Note in the picture here that the baby is further away from the breast than a newborn. Unless his mother is uncomfortable, there's no reason to suggest changing the position or the latch. Now, breast and nipple pain are two challenges that some mothers face while lactating. So I have a screenshot here of one portion of a 13-page algorithm developed by the University of North Carolina in the United States for breast and nipple pain. It's a valuable resource and good review prior to the exam for how to identify many of the causes of breast and nipple pain. Now, you don't need to write this down right now. We actually have a handout, which is located in that control panel. If you click on that, you can get the handout, and this URL is actually listed in that handout. Mastitis is an infectious process in the breast that produces localized tenderness, redness, or discoloration of the skin, and heat, together with systemic reactions of fever and malaise. Prospective studies estimate the incidence to be between 3 and 20%, depending on the definition and the length of follow-up postpartum. Technically, mastitis is an inflammation of the breast, which may or may not involve an infection. The problem can begin with engorgement, then non-infective mastitis, followed by infective mastitis, and to abscess if treatment is not introduced promptly. Symptoms include fever over 38.5 centigrade, chills, headache, flu-like body aches and symptoms. The breast is painful and swollen. The breast area is red, hot, or tender to the touch. And you may notice discoloration in the form of red blotches or streaks or bruising of the breast tissue. And so that's why the term, instead of saying that you're going to notice necessarily something which is red, you're going to notice a discoloration, potentially notice a discoloration of the skin tone, depending upon the melanated aspect of the skin. The treatment is rest, continue to feed or pump on the affected side, warm compresses, creative nursing positions, and it's important to support compliance with antibiotics if they are prescribed. Use analgesic or anti-inflammatories for discomfort, fever, and swelling. Now note here this picture, and I intentionally chose one to help you to try and see the mastitis. It can be challenging to note overt inflammation or redness in someone with darker skin tones. So for recurrent mastitis, Staphylococcus aureus is cited by Dr. Ruth Lawrence in her book, Breastfeeding, a Guide for the Medical Profession, as a common cause of breast infection. Jimenez found that Staph aureus dominated the microbiome of mastitis sufferers. However, Staph aureus was found by other researchers in the milk of asymptomatic women. In the case of recurrent mastitis, we want to take a look at the causes, and that could include delayed or inadequate treatment of the initial disease and continued milk stasis. The diagnosis can be made with a culture of the milk and the infant nasopharynx or oropharynx. Treatment options and a thorough discussion of mastitis can be found in the Academy of Breastfeeding Medicine's protocol number 4. And if you're unfamiliar with the Academy of Breastfeeding Medicine, their website is bfmed.org, or you can just go into a search engine and type in the Academy of Breastfeeding Medicine, and you should be able to find it with all of their protocols. The ABM is very generous with their protocols, and they're all available free online. A small percentage of breast infections develop into an abscess. Kinley et al. Reported that the incidence is around 5 to 10%, whereas Amir more recently reported about 3% of women in her sample developed an abscess. One theory is that health providers are more educated in the prevention of abscess. Dr. Lawrence reports an increase in abscess rate when antibiotic treatment is delayed beyond 24 hours. An abscess is a localized collection of pus that forms from an infection that has no opening for drainage. The indications for an abscess are the same as mastitis, although symptoms may be less severe because the abscess is isolated from the rest of the breast. This picture demonstrates an obvious abscess. Occasionally, an abscess can occur in the absence of any systemic symptoms. When antibiotic treatment is delayed beyond 24 hours, the abscess rate increases. So as far as treatment options are concerned, for an abscess, Kataria reviewed these options and suggested that for smaller abscesses, less than 3 centimeters, the recommended first line of treatment is fine needle aspiration, single or repeatedly, preferably under ultrasound guidance. For abscesses greater than 3 centimeters, a percutaneous suction catheter can be placed for 3 to 7 days with oral antibiotic effective against penicillin-resistant staphylococci for 10 days. For larger abscesses, the healthcare provider will incise and drain the area. A drain is placed to promote that drainage. The incision heals from the inside out, usually within a week or 2. A parent may continue to nurse on one or both breasts, depending on the location, associated pain, and medication. So pregnancy through nursing. Now, pregnancy can occur while nursing. It's important to explore the parent's feelings about continuing breastfeeding. Parents note nipple and or breast discomfort, and some report that the discomfort alerted them to the new pregnancy. Depending on the age and nursing relationships, some nurslings may be reluctant to wean. Mature milk changes back to colostrum around 4 to 5 months into the pregnancy, which may change the taste and the quantity of the milk. Now, oxytocin is released during nursing. However, the oxytocin is blocked by the progesterone. There is no need to wean a baby or child unless there is a true risk of preterm labor. There is limited data which shows an impact to the mother's nutritional status by continuing to nurse through pregnancy. Therefore, it is important that the parent is mindful of their diet. Some older babies and toddlers may stop during the pregnancy and resume after birth. Tandem nursing is a term used to describe breastfeeding 2 or more children who were not born at the same time or are different ages. It occurs when a parent nurses through their pregnancy, or if a previous child weaned during pregnancy and they may be interested in resuming. Explore the parent's feeling about tandem nursing. One of the pioneers in the lactation field, Shelley Marmette, once said, It takes the patience of Job to Tandem Nurse. If there's an issue with the infant's weight in the early days, ensure that the newborn is given priority at the breast. Some mothers will dedicate one breast to the newborn and the other to the toddler, and then switch the next day. Note here the way the older sibling has her arm around her new brother. Granted, it may be so everyone can fit on mom's lap, but it also could be a sign of affection. Sign of affection. If a parent expresses a need to wean, explore their reasons. Some families believe that weaning may increase a child's independence or help a child to sleep more at night, which may not be achieved through weaning. Gradual weaning works best for both parent and baby. It reduces the risk of severe breast pain and mastitis. In several texts on nursing a toddler, the first suggestion is don't offer the breast, but don't refuse a child's request to nurse. It's helpful to eliminate a feeding about every 2 to 4 days, and preferably not back-to-back feedings. Continue as both the parent and child accommodate to the new routine. The parent can hand express for comfort as needed. Change the daily routine so that there are alternatives to nursing which are offered and explored. You could offer food or drinks just before those regular nursing sessions. And you can breastfeed when asked, but for shorter time periods. Okay, we've gone through this kind of quickly. Are there any questions in this section or in the medication section? Let me take a look and see if there are. I think there was a question about the 10%. Sekeita, if you're here.
I answered that already in the
chat.
In the chat, but just to clarify, I can go over it now that I've put myself back on screen. So medications with a relative infant dose that is less than 10% is considered relatively safe for a full-term infant. So anything above 10% would require further caution and further assessment of the situation. I hope that clears that up, but I did put it also in the chat.
Perfect. Thank you so much.
You're welcome.
So, and remember that they will utilize generic names of medications. Sekeita referred to a few trade names, which are common in the United States, but they will use generic names.
Yeah. I also want to clarify, someone put in the questions about the L category. The only reason I put the L category on the screen is to give you an idea of safety and how safety is thought of, and the fact that almost all of the drugs that I showed where you can see that they are relatively safe, and that you just have to look at those key points. You have to consider all of the points. In addition to the L category, that is in practice, right? It is not customary for you to receive, and I'm saying not customary because I've taken the exam a couple times now, to receive a question specifically about whether this drug is an L3, L4, L5, whatever. So don't think about it like that. Think about it as though this is preparing you for whether or not to think about all the factors to consider and whether or not these drugs are generally safe. And for the most part, like I said, they're generally safe with the exceptions that I've said.
There you go. That's perfect. Thanks, Sekeita. And yes, there's Dr. Hale's publication and also the app, the corresponding app. The app, of course, is updated on a more regular basis, of course, than a publication. And so I think that's it. Oh, here we go. Someone is asking, how can I figure out what medications we'll need to memorize for the exam? It's a great question.
The point of going through thinking about how we think about tests is to not really memorize this part of it, but to know it, know the principles of it, know how, if you're given a scenario about person A was given ampicillin after birth, what should be your best response if they, suggest concerns, right? Or ask you about it. That's the level that you want to know. So there are some things that, yes, you can remember. So for instance, if you're trying to remember the cranial nerves, seriously, yeah, go ahead and do the mnemonics. Do that. But there's a part that you have to be able to clinically put the puzzles of the pieces together. And so that's why it's important, and that's why we have framed the education so that everything is not all or one. Usually there's various factors that you have to consider. So you're going to be presented with something, and that the idea is that you know the concept, you know the principles, and you know the safety issues. That is what we're hoping to impart.
True. And I will also say, it's helpful to have like a few names of categories a few names of specific, generic medications in those different categories. And so that's why we presented a few of those names so that you'll have a general idea. Also, someone just asked whether or not they're going to have to calculate relative infant dose. There is no math on the exam. So do not worry about that. You need to know sort of general principles. For example, generally how much a 3-month-old baby would take, possibly, but it's not to say there's not going to be a question necessarily which says how much does a 3-month-old baby need? Well, there's a lot of factors. So they're probably going to ask it in the context of a case study, as opposed to saying how many ounces does a 3-month-old need. So hopefully that's helpful. Also, someone asked if the questions we're going to review today are in the handout. They are not in the handout. They will not be provided later. However, if you'd like a lot of questions and you want to practice with a lot of questions, LER does have a feature called QBank, which has all of those questions, has many, many, many. We have over 500 and some questions, maybe over 550 questions in there. And so there's a lot of opportunity for you to practice through QBank and or through our exam review. You're welcome to do that. And here's a secret. Yesterday was IBCLC day, and we have a 10% discount on anything on our website. So if you haven't purchased exam review yet or QBank yet, please do, utilize that discount. I think it's available for the next couple of days. So today is Wednesday, the 3rd of March. And so, Thursday, the 3rd of March. And so you can check it out on our website. Okay, great.
Yeah, I wanted to just address one thing, Angela, because someone asking if they needed to calculate. I guess I should make it clear, the relative infant dose is done through research. That is something that HAL and researchers that really do research on these particular medications, those are determined through the research. So that is not something that you will ever have to figure out in a math equation. That is something to look up in your reference book. And I am very apologetic that I did not make that clear. Going forward, I will make that clear because I understand how that might be a little confusing for some.
This is true. And another question has come in, if we say we're doing questions here. Someone says that it's really tricky that there are several right answers on a question, right? Sekeita, you just said, what's the best answer? What's your first response? And that's a really good point. And do you have any general guidelines when working through those questions?
So when you have a question that there appears to be 2 right answers, because usually there's 2 distractors, but when there appears to be 2 right answers, think about what is the best answer, what is the best, or what is the first right thing that you could do. The other thing is when we think about, for instance, and I'm going to use an analogy, when you think about the ABCs, airway, breathing, circulation, that's how some of us think. When you think about lactation, what you want to think about is protect, promote, support. So if your answer, the answer that's going to protect, promote, and support is usually the best answer out of those 2. And so think about it like that. And that is a very good question. There always appears to be 2 answers, but trust that one is the best answer.
That's perfect. Thank you so much, Sekeita. That's great. Okay. I think we'll go ahead and dive back into the content. So we're going to talk about milk supply here. Okay, good. So here we go. So this is a picture of the neuroendocrine reflex to remind you, I'm sorry, the neuroendocrine reflex arc to remind you of the physiological mechanism of lactation. So milk synthesis is a complex interplay of the hypothalamic pituitary gonadal axis. Milk synthesis is related to the degree of breast fullness. Suckling or expression or other nipple stimulation stimulates prolactin secretion and the release of oxytocin. It is milk removal that enables milk secretion to continue. So this slide you may have seen in the anatomy and physiology, as well as the re-lactation exam review. According to Margaret Neville and Jane Morton, failed lactogenesis can be described as preglandular, glandular, or postglandular. An example of preglandular would be hormonal causes, such as retained placenta or lack of pituitary prolactin. Glandular causes might be surgical procedures, such as reduction mammoplasty or possibly insufficient mammary tissue. Postglandular could be any cause for ineffective or infrequent milk removal. This would include the iatrogenic causes for lactation failure, and those are which are impacted by policies and procedures in hospitals or by healthcare providers, which can have a negative impact on milk production. A parent's perception of milk supply in the early hours and days after birth could be included in here as well. It's a common perception, for example, that a sleeping or quiet baby is a happy baby. Parents may misinterpret baby's lack of settling post-feed as a sign that baby isn't getting enough and supplement. Parents may interpret normal newborn nighttime circadian rhythms as a sign that the baby is hungry and assume lack of milk. True failed lactogenesis can come from those three sources. So preglandular, glandular, and postglandular. Postglandular would be any cause for ineffective or infrequent milk removal, which is what I just mentioned. So iatrogenic reasons for lactation failure include the separation of the birthing person and the baby, pacifier use, and perceived insufficient milk by staff or family, which leads to supplementation. Interventions which require supplementation of milk supply, which is not simultaneously supported through hand expression or pumping. So consider the supplementation scenario. When parents are told they have to supplement their baby, the parent may feel that breastfeeding has failed and worried about resumption. Well-meaning healthcare providers may not encourage resumption of breastfeeding if interventions are effective. Common scenarios include a baby diagnosed with hyperbilirubinemia in the early days after birth and supplemented with breast milk substitutes, or a 2-week-old baby who isn't gaining effectively and begins to supplement in order to gain the weight. In both of those cases, the parents may be afraid to resume exclusive breastfeeding, and healthcare providers may not have the time to create a care plan to help the baby to return to exclusive breastfeeding. Finally, there are some cultural beliefs that create a barrier to normal breastfeeding, such as colostrum not being enough or is bad for the baby. So then there are anomalies of maternal breast tissue. There are surgical interruptions in the breast, such as a biopsy, a reduction or augmentation, a chest tube as a preterm baby, or thoracotomy placed prior to breast development, mammary hypoplasia or insufficient glandular tissue, breast asymmetry, including intramammary distance or the space between the breasts. So chronic illness, maternal disease, hypo or hyperthyroidism, lupus, Parkinson's, diabetes, and hypertension. Acute illness or birth-related complications include hemorrhage after birth, especially causing large sudden drop in blood pressure and or requiring a blood transfusion. Now, as a point of reference, 500 milliliters of blood loss is considered normal. Hemorrhage may cause damage to the pituitary, ranging from a mild insult to a major infarction. Sheehan's syndrome is a severe hemorrhage and drop in blood pressure that may result in necrosis of the pituitary. Hormonal issues were referred to a few slides ago and worth mentioning again. Irregular menses, infertility, and obesity-related issues, PCOS. Weight loss surgery, specifically gastric bypass surgery, can impact the amount of nutrient absorption. Now, each one of these points could be reviewed in depth on the other factors for a delayed lactogenesis 2. So if you have further questions about the specifics, please refer to your notes, your lessons, or the literature. So other factors include premature delivery, insulin-dependent diabetes mellitus or gestational diabetes. Metabolic status or health refers to an interesting study from Namsen, Rivers, Dongol, and Huang in 2012, which described 3 risk factors for delayed lactogenesis: higher BMI, increased parental age, and larger infant birth weight. And when I say increased parental age, I mean the pregnant person. These are known correlates with carbohydrate intolerance and systemic inflammation. Now, there is a fat-phobic bias, and staff which are usually unaware of their bias. And we want to give a shout out to Kristen Cavuto for bringing this important concept to our attention. So other issues with delayed lactogenesis 2 are hypertension, high levels of stress to the mother and the fetus during birth, cesarean birth, especially when urgent, prolonged stage 2 of labor, which is greater than an hour, augmentation of labor with intravenous oxytocin, forceps or vacuum delivery, timing of the first breastfeed or the first breast stimulation following delivery, significant edema of the extremities, and endocrine disturbances. So as you can see, there are complex interrelations which exist amongst the various factors that may affect lactogenesis. Whether the delay of lactogenesis 2 is a maternal physiological response due to delayed or insufficient suckling or a combination of factors has not been clearly identified. Early, frequent, and effective breastfeeding appears to be the most important factor in establishing normal lactation. And frankly, I would argue that skin-to-skin and milk expression in the first hours after birth are the key factors to counter any possible risk factors. Those of you who work in a hospital setting can understand how that may be impeded with any of the above diagnoses. Any issues which affect sucking or suckling frequency may affect the initiation and calibration of milk production. The baby may not be capable of sufficient milk removal to initiate and maintain an adequate supply. Important factors include gestational age, premature infants, of course. Remember that late preterm infants may not suckle well enough for adequate milk removal. The infant's oral and facial anatomy. Any tongue mobility restriction can impact not only maternal nipple discomfort, but also the ability to remove milk. Palatal issues, obviously, including a partial or complete cleft of the hard or soft palate, but also includes a high palate, a bubble palate, or a channel palate. And any airway issues such as laryngomalacia or tracheomalacia. Long-term, the issues on the previous slide can impact the initiation and calibration of the milk supply, but the following can impact the maintenance of milk production. In the immediate postpartum period, this would mean infant hypotonia or hypertonia, birth trauma pains, such as with a shoulder dystocia, or the use of forceps or vacuum, cardiac or forceps or respiratory issues. Now, a long-term impact could include infant facial anomalies with the tongue or the palate, and sensory integration issues. Prenatal education can reduce the use of supplementation in the early days by parents who believe the baby isn't getting enough. During the hospital stay, it's important to have frequent skin-to-skin contact. You really can't overdo it. Frequent colostrum or milk removal. Hand expression seems to work best. A quick note, for parents who are pumping for their premature infant or who are having trouble extracting an appropriate amount, utilization of the other senses can help with milk ejection reflex. A study noted an improved milk output when the parent was looking at pictures of their baby and or listening to the baby's cry or coos, as well as smelling the baby's t-shirt or blanket from the day before. Normal newborn circadian rhythms, it's important to have that education. Visuals of the newborn stomach and the nominal nutritional requirements in those early days. Realistic expectations help to set, and providing anticipatory guidance prior really does help to set parents up for success so they know that their baby is going to be awake frequently in the middle of the night. Education on alternative supplementation techniques if they're required, and follow-up. Okay, any questions? I'm going to take another pause for just a moment and check the questions and see if there's anything in the app about questions. So someone asked if it's possible to induce lactation for a newly postmenopausal person. Great question. I do believe that the Goldfarb-Newman algorithm does address that issue. And so I would say take a look at that reference. We also have a wonderful lesson, a conference on our website from Alyssa Schnell, which talks about breastfeeding without birthing. And so that may be a fantastic resource as well. Sekeita?
Yeah, I wanted to jump in because there was some discussion about endocrine, autocrine, and what that means. When you think about it, and I believe it's from the Human Lactation book, but when you think about endocrine, think about it as hormonally driven. And when you think about autocrine, that means it's driven by milk removal. So that's a simple way to simplify how you think about the endocrine versus the autocrine systems. There is also a great graph when we talk about hormones. There's a shift in hormones that happens that signifies when you're in the somewhat of the autocrine, no, not somewhat, you're in it, because what happens is once the placenta is delivered, then that makes way for prolactin to increase. So if you want to really kind of get a handle on the autocrine versus endocrine, please refer to your textbook and find that graph, whichever one you're using, and it'll spell it out for you so that you can understand exactly how they differ.
Absolutely, that's an important point to note. And again, you probably won't see something on the exam which says at what moment does it shift, because it is that gradual piece. And so that's why I said it corresponds. You know, I'll see parents with, oh, I don't have enough milk, and they're calling me. I usually get those, visits at around that 2 to 3 week mark, and again around that, 4-month mark. And so it's when the person, when the baby is doing something developmentally different, when the parent had just had this copious milk supply, and then all of a sudden they say it's reduced, but what I find interesting and how I actually can contextualize it is I tell the parent that their milk supply is normalizing. Remember, baby, a person who's given birth, a lactating person, has 2 breasts. And so each breast will produce 100% of what a baby needs. Therefore, parents have double of what one baby needs. Now, of course, if we're talking multiples, that's another conversation. But for one baby, a singleton, a parent has more than abundant amount of milk. And so the breasts will go from a 200% capacity down to only what that baby needs. And then there's that gradual shift. So that's great. Someone else asked a question about the most current research and whether or not that's going to be on the exam. And I will say that that anything that was published probably within the past year or 2 is not going to be on the exam. And the reason why is because the exam actually was probably written a couple of years ago, and definitely not something which was just published at the beginning of this year. There's no way. And the reason, it has to do with the exam process. And you can go to our blog and find out where I actually wrote a blog about what that exam process is, about how they develop the exam. But regardless, you're not going to need to know something that was just published. And so do be mindful of that. You don't need to study those things. And also something else about research, and that is that the research would need to change the practice. It would need to be significant enough, large enough, or different enough to actually change practice, as well as to change the books. And so unless it's something which is just groundbreaking, it's probably not going to be on the exam. And even if it is, it still needs to get into the clinical practice guidelines. And remember, this is an international exam. You know, one organization in one country may update clinical practice guidelines, and you think, oh wow, this is the greatest thing ever, but other countries haven't adopted it, or those guidelines are not utilized ubiquitously around the world, nor have they been translated into other languages. And so be mindful, this is an international exam. Therefore, if something changes and there's a new piece of research, it takes a long time in order to get that into practice and for you to be tested on it on the exam. Okay,
Yeah,
great.
Angela, there's another question, and it says, will the exam have metric as well as imperial?
Yes, it will. So it will have, actually, it's probably going to list it will list the metric first and then the imperial. So there we go. Let's see. All right. Okay, I will go ahead and continue. I think that, and yes, someone is commenting on how we use non-gendered pronouns for lactating and birthing folks. Indeed, it is something that we are weaving into all of our content. And so I'm glad you recognize that it is something that we are working hard to ensure that all people are seen, especially in our webinars. Okay, great. So now we're going to switch over to research. So here we have variables in experimental study. The dependent variable is what the independent variable acted upon. For example, in a study on breast pumps, the volume of breast milk obtained when using several types of pumps was compared. The volume of milk is the dependent variable, and the type of pump is the independent variable. Now consider what we know about the effectiveness of pumping. It can be impacted by a number of factors. Therefore, confounding variables in this example might be the privacy of the place where the parent pumped. That might lower the amount that they're able to extract, or the time of day can be a confounding factor. So those are important things to note when you're actually reviewing research yourself. Now I just want to review some quickly review some frequently used terms. So the standard deviation is a measure of how spread out the numbers are. So in this example, 68% will fall in the first standard deviation. You can see that if you notice the green in those middle two columns. 95% will fall into the first and second standard deviation, which is noted by the light blue, or not the first two, but the second two. And then 99.7% will fall into the first, second, and third standard deviation. And there's only a few in that fourth standard deviation. Now, statistical significance is the level of certainty in the results of a study. If we want to be 99% confident of our results, we set the significance level at 0.01. If we want to be 95% confident of our results, we set the significance level at 0.05, which is most medical research. A comment about bias. There are different types of bias, and it can influence research. For example, let's say there's a piece of research that looks at the effectiveness of a breast pump, specifically in this number of cycles per minute. You note the university who supported the research is funded by a specific breast pump company. The researcher whose university receives funding from a pump company could be biased in their study design and/or the interpretation of the results. Informed consent. Subjects need to be informed about their rights, equipment, or medications used, procedures, confidentiality, and how to withdraw from a study at any time and if there are any rewards for participation. Okay, great. So just a couple of questions here. Now this is our question time. So yes, we answered a few questions just a few minutes ago, but now we're going to pop into the poll questions that we have through this platform of GoToWebinar. So now the poll doesn't allow for the picture and the slide to show up on the poll. And so Jill is going to be monitoring the poll, and she will find out if the results show up in that recording. So I think that they will not be in the recording, but just so that hopefully you can practice here. So now what we're going to do here is that we're talking about some overall concepts and not what may be done at your facility or in your country. For example, you may see a reference to a varicella zoster in one of the subsequent questions. There's a hint. During the previous exam prep, we reviewed the recommendations for varicella zoster. We found 3 different answers. When that occurs, please take a look at the international resource. If there isn't an international resource or a clear-cut answer, understand the why. One may be able to assume that there will not be a question about it on the IBLCE exam if there is a lot of confusion. Okay, so now going to the questions, I'm going to click and go to the first poll question. Jill, I hope you're ready. Okay, we're going to leave the poll open for about 30, 45 seconds. That should be enough to answer the question. And we're going to answer it live as well. So the question here, great, the poll is open, fantastic. Physical presentation which may contribute to low milk supply. A, significant inframammary fold. B, breast cup size less than a B. C, significant intramammary distance. Or D, hypoplasia of the superior breast tissue. Now you can see why you need to know those medical terms. Okay, we'll give this poll another few moments. I'm taking a look at the poll as well, just to see. Okay, great. Almost all of you have voted, and so go ahead and close out the poll. Most of you thought the answer was C, significant intramammary distance. However, the correct answer is D. So it's a little tricky, and the reason why is because there is significant distance between the breasts, so the intramammary distance, it can be associated with hypoplasia. Cup size, of course, doesn't matter. Hypoplasia of the upper breast does not indicate insufficient glandular tissue. Hypoplasia of the lower medial and lateral quadrants do. Sekeita, did I get that incorrect? Hypoplasia of the superior breast tissue. Is that right? Is answer D correct? I'm just checking myself here. I think I'm right, so I'm going to move on. If I'm wrong, y'all are going to call me on it. Okay, great. So now let's go to the second poll question. The question is, a postglandular reason for insufficient milk production is A, early introduction of hand expression, B, pacifier use, C, retained placenta, D, previous breast biopsy with periareolar incision. Okay, this is a postglandular reason for insufficient milk production. So about a third of you have voted, and we're not fooling anybody. Postglandular. Thank you for the responding. And we're going to go ahead and close, and there we go. So most of you did pick the correct answer, which is B. Pacifier use is a postglandular reason for insufficient milk production. Okay, great. All right, let's go on to the next question. So while reviewing your postpartum patient's chart, you see that they receive Pitocin, which is synthetic oxytocin, and Methergin, which is, oh goodness, methylorgonavine maleate. Apologies if I didn't say that correctly. After a vaginal delivery. You know that this patient most likely, A, experienced a normal blood loss, B, experienced excessive blood loss, C, had twins, D, will not be able to breastfeed. So we'll let this go just a little bit longer, Jill, just because of my mispronouncing of Methergin. I don't think I'll practice at this time. I'll practice later. But with half of you voting, we're not fooling a single person here, really. A strong majority of you have chosen the correct answer. Okay, that's good, Jill. Go ahead and close it out. And the correct answer is B. So the first line medication, which is used in the management of excessive blood loss during the third and fourth stage of labor, is Pitocin. If bleeding does not decrease, a second medication is indicated. Providers may choose among several second line medications, including Methergin. A is not correct because the management of normal blood loss does not require two medications. C is not correct because delivery of twins does not require 2 medications. And D is incorrect because excessive blood loss does not necessarily mean breastfeeding will be unsuccessful. And so if you'd like the rationales that I have to this question, we actually have rationales in all of our questions, which are in QBank. And so that is something that we are very proud of as well, is that we provide you with references as well as a citation so you can do further study. Okay, moving on to the next question. Now we're going to talk about research. Lilo Lactation Consultant did a study in their hospital where she surveyed the parents' duration of breastfeeding. She found a range was 1 week to 18 months with a mean of 8 months. What type of research is this? A, quantitative, B, qualitative, C, historical, or D, epidemiological? Okay, cool. The poll is open. I'm going to take a little sip of water. Most of you know this one as well. Thank you very much. Okay, great. So yes, most of you, 81% of you, stated it's quantitative, and that is correct. And the reason why is because it's based on data, it's not experimental, and there's not an attempt to determine causality. Okay, great. Now going to the next question. There we go. Forgot I had that there. So there is the difference between qualitative research and quantitative research. Okay, next question. Lilo is a busy person, and she did a study in her hospital where she surveyed parents about their satisfaction with breastfeeding and what problems they encountered. What type of research is this? A, quantitative, B, qualitative, C, historical, or D, epidemiological? Okay, so in this one, and actually I believe we've just closed the poll, so I apologize for closing that quickly, but most of you had that one, and the answer is qualitative. And so once again, I'm going to put up the slide which shows the difference between qualitative and quantitative. So there you go. Okay, moving on to the next question. We have here a question about iron. So iron levels are low in breast milk. What instruction should parents be given? A, supplement with iron drops until the baby begins solid foods fortified with iron. B, breastfeed, no supplementation needed. C, breastfeed and supplement at 6 months with iron fortified foods. D, increase the amount of iron in the parent's diet and increase the amount of iron, which will increase the amount of iron in the breast milk. Okay. So this is a good question, and the reason why is because I know that there may be a little bit of differing opinions here. And so this is a really good time when you would want to take a look at what those international guidelines are. Okay, good. Majority of you have voted. Therefore, the answer is number 3. So breastfeed and supplement at 6 months with iron fortified foods. Additional iron intake by the parent will not increase the iron levels in their breast milk, even if the parent is anemic. Iron supplements taken by the parent may produce constipation in the baby. Anemia in the nursing parent has been associated with poor milk supply, however. Therefore, the correct answer is breastfeed and supplement at 6 months with iron fortified foods. Okay, great. Here we go, the next question. Vitamin D levels are low in breast milk. What should be done? Supplement baby with vitamin D until solids are started. Breastfeed, no supplementation needed. Breastfeed and spend a half hour outdoors daily. D, baby should be supplemented with 400 IUs of vitamin D daily. Okay, we're going to leave this on as well for probably about a minute. And again, I know that this is something where you may see different things in different parts, in different resources that you may be studying. And so again, we want to go with the international resources. Remember that no one, not even LER, knows exactly what's going to be on the exam, nor whether or not some therapies, while they may be used commonly in your country or in your practice, they may not necessarily be utilized or recommended internationally. Okay, great. So we close the poll, and let me just check. I close my screen. Great, most of you got it correct, which is babies should be supplemented with 400 IUs of vitamin D daily. And so since this is something which is a question, I actually am going to quote from the World Health Organization's recommendations on vitamin D, which states there appears to be consistency across the world that newborn infants are at an elevated risk of vitamin D deficiency, and that a vitamin D supplement to exclusive breastfeeding is highly recommended in the primary prevention of vitamin D deficiency and rickets. So, correct answer is D. Okay, halfway through now. Jill, don't start this poll. Oh, you started the poll. Okay, I think you can see this picture. Y'all will let me know if you can't, but take a look at this baby. And how old is this baby? All right, so what are some of the hints you're looking for here? Well, you want to take a look at that social smile, right? The baby is able to lift the head to about 45 degrees. The baby is able to hold up their head just for a few seconds, and the baby will visually search to locate that familiar face or sound. So you notice here that this little one can hold their head up and push up when lying down, lying on their abdomen. And so the correct answer is 2 months. So yes, at 2 months, they may not be able to sustain this pose for very long, but the parents are at, notice that the parents are at their level and taking a quick photo to show how strong she is. So indeed, that would be the correct answer. It'd be 2 months. Oh, there's the questions there. So I apologize, didn't click through there. All right, great. Moving on to the next question. Which of the following viruses are most likely to be transmitted to the infant through breast milk from an infected parent? A, hepatitis C, B, herpes simplex virus, C, varicella zoster virus, or D, cytomegalovirus. Okay, give you a few seconds to answer this question. Most likely to be transmitted to the infant through breast milk from an infected parent. This one's a little trickier. Let's give it another few seconds, Jill. Okay, great. Most of you have voted, and the correct answer is D. Cytomegalovirus, or CMV, transmission from parent to infant occurs in 60 to 70% of breastfeeding dyads, where the breastfeeding parent is infected with CMV. However, healthy infants who acquire the infection in this manner are almost always asymptomatic, and breastfeeding should be encouraged. Premature infants and immunosuppressed infants are at a higher risk of complications from CMV infection, and there is debate about whether these infants should receive CMV positive breast milk. Herpes simplex virus and hepatitis C are unlikely to be transmitted via breast milk. Varicella zoster virus the one which causes chickenpox, and zoster. Infected parents should be encouraged to breastfeed. The infant should be protected from direct contact with the skin lesions. And so I know earlier someone asked a question about HIV, and the guidance about HIV and whether or not to continue breastfeeding is country specific. However, for example, in the United States, it is not recommended that the HIV positive parent breastfeed or provide breast milk for their baby, but yet in other countries it is recommended for breastfeeding. And so again, you want to go with that international guidance regarding HIV. Okay, moving on to the next question. Here we go. Tyler is a vegan. What would you suggest to ensure adequate nutrition for the parent and the baby? So, protein from beans and rice. B, minerals such as magnesium and selenium from grains. C, folate from dark green leafy vegetables. Or D, B12 from fortified foods or supplements. Okay, so we'll leave this open. Again, this is one I don't think we're fooling many folks on this one, as far as a vegan's diet and what they may be deficient in. So great, most of you have voted, so we'll close it out. And yes, the majority of you got the correct answer, which is B12. So vegan diets include no animal products. And the only dietary source, which are the only dietary source of vitamin B12. To avoid a B12 deficiency, vegan nursing parents and those who consume very little animal protein may need to take steps to ensure they receive adequate B12, either from foods enriched with B12 or by taking regular B12 supplements. Okay, great. Next question. The primary reason for supplying breast milk for premature infants is to A, improve bonding between breastfeeding, chest-feeding parent and baby, B, to assure continued breastfeeding and chest feeding after discharge, C, prevent necrotizing enterocolitis, D, improve neurological outcomes. Okay, great. So what answer do you think is correct? What is the primary reason? That's the key word in the STEM. That's the primary reason. Okay, great. And again, most of you got this one correct as well, which is C, preventing necrotizing enterocolitis. So that is the primary reason for supplying breast milk to premature infants. Okay, great. Next question. The risk of skin-to-skin care in newborn infants include respiratory instability, sudden unexpected postnatal collapse, hypothermia, sudden unexpected infant death. So here we are. What are the risks of skin-to-skin? It's really nice to see the results or how people are answering live. And the reason why it's nice to see is that the answer has changed since we first started presenting this just a few years ago. A little more than half of you have voted. The risk of skin-to-skin in newborn infants include. Okay, great. Let's go ahead and close the poll, and the answer is B, sudden unexpected postnatal collapse. And so do be mindful that that is a risk for skin-to-skin care. There's actually a wonderful toolkit by which you can review the things to help to avoid sudden unexpected postnatal collapse. And so I would suggest reviewing that information. You know, one of the parameters, for example, is to ensure that the infant's head and face, the infant's face is seen and that the baby does not have their neck turned to one side. So I don't remember all the parameters right at this moment, but indeed, those are some things to consider. Now, before we move on, so hold up a second, Jill. Before I move on to the next question, I want to show people the picture. I understand that the picture in that previous slide wasn't visible. So let me show the slide in the picture for a few seconds, and I'll let you know when to open the poll. So here, this technique, which you can see in this picture, is useful for all infants except premature infants, infants with Down syndrome, neurological impairment, or infants with a type 3 ankyloglossia. So take a look at the picture, and this infant is useful except. Okay, go ahead and go to the next. Go ahead and open the poll, Jill. So the answer is premature infants, Down syndrome, or infants diagnosed with Down syndrome. Let me clarify that and correct myself. Neurological impairment, or infants with type 3 ankyloglossia. I'm smiling as I'm seeing the results come in. Sorry, I wish y'all could see it too. Okay, great. Go ahead and close it out. And so the answer is D, infants with type 3 ankyloglossia. So that is the correct answer. And so this technique is utilized. This is known as a straddle hold. So you see that the parent is sitting back a bit and the infant is facing the parent. And you'll notice that it's the danner or dancer hand position where the infant's, where you place the thumb as well as the fingers on the infant's cheeks in order to help with muscular stability, and you help to improve the intraoral pressure by utilizing this. And so by utilizing the technique of putting slight pressure on, you know, supporting the jaw with the palm of the hand and then putting slight pressure with the fingers as well as with the thumb. And so in this way, you are supporting that intraoral vacuum and the stability of the musculature for the infant. And one caveat is that it is best practice not to have negative STEM questions, but we have heard that indeed there may be negative STEM questions on the exam. So that's an important thing to note as well. And I know, for example, type 3 ankyloglossia is something which is a hot topic. You know, ankyloglossia in general is a hot topic. I just want to point out that not all answers are ankyloglossia. And so do be mindful of that, especially when we're basing what we do, how we do on the evidence, and that's what you're going to be tested on. Okay, last question. The World Health Organization guidelines for preparing powdered infant formula recommends boil the bottles and teats for 20 minutes. So a rolling boil. Boil the water used for mixing for 20 minutes. So a rolling boil. Mix the measured amount of powdered formula and hot water to 70 degrees centigrade or 158 degrees Fahrenheit. D, store prepared bottles in refrigeration for up to 72 hours. Okay, so what is the correct answer according to the World Health Organization? I think this one's a little trickier. Y'all are a little hesitant about voting. It's okay. We're not going to record these answers and say whether or not you missed something. So go ahead and give it a try. Okay, great. So this may be an opportunity where people should study a bit and take a look at the World Health Organization's recommendation. The correct answer is C. Mix the measured amount of powdered formula and hot water, and notice that number which is there, 70 degrees centigrade and 158 Fahrenheit. That is something which is accurate. So yes, you do need to boil the bottles and teats, but it doesn't need to be at a rolling boil for 20 minutes. And yes, you do need to boil the water used for mixing, but again, you don't have to boil it for 20 minutes. That rolling boil doesn't need to happen for 20 minutes. It's you bring the water temperature up to that point, and as soon as it gets to the boil, that's usually where it's about 70 degrees centigrade or 158 Fahrenheit, and then you turn it off, and then you can mix it with the powder. Make sure it's the appropriate amount of the powder, and then once it cools, you can feed it directly to the baby. So, and D is incorrect because it states to store prepared bottles in refrigeration for up to 72 hours. The answer is actually 24 hours. So you can store powdered infant formula, which you make into, formula, you know, you combine it with the water, and that can be stored for up to 24 hours. Okay, great. So I think I will now, if Sekeita is ready, I will turn it over to Sekeita, who is going to have, oh, got questions? What you got, Sekeita?
I just want us to go back to that first question and just really clear it up while we're here live, if that's not.
I do apologize. I'm looking at that question myself and going, wait, what? Let's see. There we go. Okay, great. So the physical breast presentation, which may contribute to low milk supply.
Right. The answer is C.
It is C. Okay.
Yeah. And if you want me to, I can explain real quick the rationale behind it. So the significant difference between the breast, which is also known as the intramammary distance, may be associated with hypoplasia. Notice may, the words may contribute. Every single word in this in the question you want to read. Cup size doesn't matter. Hypoplasia of the upper breast tissue does not indicate insufficient glandular tissue, but hypoplasia of the lower medial and lateral quadrants do. And so I just wanted to, when you said, Sekeita, what's the answer? I'm like, okay, let me make sure, let me look this up. But before we move on to the next, I just wanted to, in my all conscious, be able to answer that question before we move on.
Well, I just feel happy about myself that I was able to notice that and not and not continue to perpetuate something which was inaccurate. So thank you very much. Okay, so what about exam day survival guide? What do you have for us?
Ooh, I appreciate you, Angela. Thank you. Exam day survival. So what I would like for us all to do right now is just take a deep breath, a deep cleansing breath. And I just want you to have awareness of that your shoulders might be tight, something, just however you experience stress. The reason being is we just went over a ton of information, and there's still much more. This was not designed to be all inclusive, but take this as an opportunity to prepare for the exam. And so I know that was a lot, but stick with me, because I'm going to talk about just some key things that you want to do to, now that you're preparing, you're studying, you're almost ready, to make sure that you're able to successfully complete and take the exam without hiccup. So first of all, give yourselves a hand for the test that's coming up the end of March through April. You're almost there. And just remember that preparing for this exam requires passion, dedication, and endurance. And you're almost there. And so arriving at the exam day is a reflection of that. Arriving at that day prepared and knowing all the things that you've learned over these last few years, just know that that is all the reflection of that passion, that dedication, and your endurance. And so just, kudos to everyone on this call that's here trying to say, okay, am I prepared? Am I not? What do I need to work on? So the last few days, we're there, and I'm saying few days because I recognize there's about 20 something days, maybe like 25 days until the first person may be sitting for their exam. But stay connected to your passion. I know it might seem daunting. I know it seems stressful, but remember, stay connected. Stay connected to your why, your reason. Why are you doing this? Celebrate it and just be proud. The one thing that you can do to ensure trust in your preparation is to actually prepare. So one of the things I tell my kids all the time is the 5 Ps. Proper preparation prevents poor performance. And I stand by that always. And so if you are properly preparing, trust in that preparation. And I'll talk about a little bit more in one of the later slides. Remember, we started off with breathing deeply. That always helps. Always, always, always. I'm going to tell you to remember this also when you're taking an exam and you get a question, such as some of the questions that Angela just went over, and you get a question and you're like, oh, it's escaping my mind, but you get so stressed out about it. Just remember, take a breath. You can flag that question and you can return to that question, but you really want to try to just, maintain a little level of calmness, so that you will be able to think rationally about the question and the question that's being asked. So this is extremely, extremely, extremely important. Before the exam day, there is lots of changes that have happened in light of, COVID. And when I say that, I mean, not that you've taken the exam before. Some of you may have, some of you may not. But what I will say is that be sure to double check and recheck. For example, I actually, this morning, as I was thinking about it, knowing that now there will be opportunities for people to take the test exam through remote proctoring, but also at a test center. As of September 21st, Prometric, which is the test center that's being used, no longer accept any identifications that are more than 90 days expired. So that is new. And so I said that to say there's two websites that I really will promote, and I actually will drop them in the chat. It is really going over to the live remote proctoring checklist. I will review some of those, but it's important for you to read it. I know in this day and age, with text and technology, we've really gotten into this habit of skimming things. Skim, skim, skim. I'm going to really caution you to read for understanding, because it's so important. You've made it to this exam day. It's so important. Also, there's the IBLCE has that checklist, but also there is the Prometric.com. They have the COVID-19 update test center, and so they're also updating, and that's another link that I will drop in the chat. Just when I'm getting ready to conclude. But so before exam day, remember your confirmation number. Know what to expect. If you're doing live proctoring, know the computer system requirements. Understand that you will not be able to test on a tablet. You won't be able to. You really need stable internet connection. Sometimes it's advisable if you've ever had any shoddy internet connection, be in a spot where you have great connection, or plug into your Ethernet, which can help. Prometric, as far as a live remote proctoring, Prometric will have 3 online agents who will be able to assist you with your setup on the day of the exam. And they'll have a readiness agent, a security agent, and then the remote proctor. The readiness agent will be the one to assist you and set up and conduct all the ID checks. And that will include, that's the reason why you'll need your photo ID at the beginning of the exam. You'll also have, they'll do an environmental check of your workspace. And that means that your camera has to be able to, you can have a camera, but to a webcam, I'm sorry, that moves, or you will have to move your computer. You will have to show whether or not you have to show the environment, everything around your environment. Let's see, 3 security checks. And all right, now, before moving forward, I just want to read a couple things about the laptop. You have to use a laptop or desktop, and you cannot have a dual monitor configuration. It's just not permitted. Some people will say, oh, a Microsoft Surface Pro is a laptop. Well, for the purposes of a live proctored exam, that is considered a tablet. So if you have a Microsoft Surface Pro, then please know that that is not an acceptable, that won't be acceptable on the day of the exam. I've already talked about your webcam. I've already talked about the power source. Make sure that you are plugged directly into a power source for your exam. You would hate for your computer to just completely zone out in the middle of your test. Also, make sure you have working speakers and microphone and wired headphones. And I'm sorry, last, your hardware. Wired headphones and microphones are allowed. All right, now we can move to the next one. So this has happened to a couple people, and this is the reason why I'm prefacing this, and the reason why I said make sure you read it, because leaving the view of the web camera without acknowledgement from the proctor, including during your scheduled break, will result in an immediate dismissal from your examination. That's one. 2, no one can enter the room during the exam. So it's important to make sure that, you know, and I'm gonna just, because this is real life, my dog can open the door here, make sure that no one is around that can interrupt or come into that room. And make sure that when you're in a testing location, it's quiet. You also want to speak. You cannot speak or receive assistance from anyone at all. That is automatic termination. If you turn off your light or turn off your computer, automatic termination. If you even just move your testing location, which means you pick up your laptop and just want to get a little bit more comfortable and you want to sit on the sofa, automatic termination. So again, the website is there. I would definitely say go ahead, take a look. Also play around with your computer, position your computer and know that you're in an area for the strongest signal. So there are some requirements for your system. Again, these are all listed on the Prometric website, but you will have to install the ProProctor application and perform a system check. Your screen resolution, these are the specification, has to be at least 1024 by 768. Your operating system has to be a certain specification, and for Windows is 8.1 or higher, and for Mac is 10.13 or higher. You should use for the best experience, you should use the latest Google Chrome. And when I say latest, I mean making sure that it's updated. Your webcam resolution has to be 6040 by 480. And then again, your audio, working speakers and a microphone are required, and only wired devices are allowed. So there's no Bluetooth wireless headphones that can be used. Your internet speeds should be 0.5 to 1 megabytes per second or greater. And I'm going to just ask you this question, and I'm not going to give you the answer, but if this is something you do not know, this is an answer you want to have. Do you know what to do if you have technical difficulties during the exam? What should you do, right? Those are things that you want to know before going into the test date. So, preparing to sit at a testing site. Remember I said there will be some that will be able to sit at a testing site. There will, and some will do live proctoring, but you also want to read about the social distancing measures. Read the fact that masks may or may not be required. Here is the thing right now, we're in this fluid situation where there are, and this is an international exam. So the rules might be different in different areas. And that's why I'm suggesting making sure that you know what's required and expected of you. This says you may wear gloves. Again, one of the websites when I was looking at it today talked about hand sanitizer. And so I think this is going to be specific to your geographic area and where you will be sitting for the exam. So again, review the guidelines, arrive early knowing the guidelines. And again, there is the IBLCE has the COVID facts, frequently asked questions on their website. And China has specific policies. So if you're in China, you want to check that out. So before exam day, after you've done your readiness check, plan to be alone, no pets or people. Plan an area where your internet is strongest and you have good lighting. and suggest, even if you know there are older or other people in your home, suggest that everyone stays off the internet during the time of your exam. No streaming, no social media, nothing. It should be just only you with your Wi-Fi. Consider your hardware hardwire Ethernet cable, like I suggested earlier, and just ensure that you will have quiet time, that you can't hear somebody crying in the other room, or you know, sometimes your pet may be whining. You want to just make sure that you're able to take the exam in a quiet space. Before exam day, try to think of a time when you had to take an exam before you even think about like all of this other stuff, right? Think about exams that you've taken in the past and think about what worked for you. What worked for you? And if you feel like you got a good handle on it and you know what to do, stick with that. But if you're nervous and like, have I done everything I've done? I mean, the last time some people have taken a test could be years and years and years ago. And sometimes you're like, well, I don't really remember. Certain things can help you calm down. But again, after you've prepared, take steps that have helped you in the past. You may consider an exam playlist that can build up on your confidence. Because taking a test is knowledge. Yes, it's a whole bunch of knowledge, but it also can be anxiety producing. So make a playlist, include some of your favorite songs or songs that make you feel good or energized, or perhaps find a podcast that makes you laugh, or a podcast that's more of meditation that can help to center you. You can write notes to yourself, like you can do it, you know, after taking earlier today, after having that first session, there were so many questions about so many things. And again, I know that can be overwhelming, but start to write notes to yourself today. You can do it. Place it on your bathroom mirror, your refrigerator, somewhere that you frequent a lot, so that those messages are there and you're centering yourself as you prepare to be, you know, taking this exam at the end of this month or early next month. So I've already talked about taking your exam temperature. I think I got ahead of myself. What worked for you in the past? Do that. If it didn't work for you, don't do that. Simple as that. Find another way. Sometimes it helps to bounce ideas or to study with a study group. Sometimes it doesn't. Sometimes people are solo. Sometimes people are a mixture. I know that for me, the last time I sat for the exam, which was a couple years ago, I was able to sit with someone and they would say a key word and it would jog my memory or something. And it's like, oh, okay, yeah, this. Or I would say something and they'd be like, oh, really? Wait a minute. I don't think I know much about that. That can be a jump off point, not stating that you have to do that every single time, but that's another strategy or another way to prepare. Before the exam, the night before the exam, try not to cram. Try not to cram. The night before the exam, you just want to center yourself. You want to find your inner calm. You want to do some meditation because trying to cram and trying to do, unless you've not prepared, you know, that's a different story. But hopefully after today, it will be a real intentional preparation. So I'll say all of the things that you are like, well, I know this, I got this, then you don't need to focus on that. Focus on the things that you need to tighten up on. But the night before, try to just eat, relax, watch a comedy, whatever it is that's gonna fill your cup so that you can get your nerves practiced in a more of a calm way. Remember, this is an international exam. For those of us in the US, this is not a US specific exam. And I'm saying that because we often, there was a question in in the questions in the chat that said, can we talk about HIV? Remember, this is an international exam. So you really want to review HIV protocol as it pertains to the World Health Organization. But really and truly, the higher resource areas are advise against HIV, and certain other areas may, and the research is changing, so about HIV and the protocol. But just remember that other key things, hand expression over pumping, because not everyone has access to an electric pump. Some of the things that, and I think I might be skipping over. I think I'm skipping over, but anyways, think about I'm talking about exam strategies now, so I think I am skipping over. But this slide is eat something your body is used to, wear comfortable clothes, trust your preparation. Perfection is just not the goal, just do your best and you're ready. Now I think we're going on to, thank you, Angela. Next slide. Test format. There's going to be 175 total questions. There's 2 parts, multiple choice, and then images. Somewhat, Angela, the questions she gave you really they're not the exam questions, but they are a simulation of what to expect. The test will be 4 hours in duration, and there's 30 extra minutes if the exam is not in your primary language. Each question has only 1 correct answer, and there's no penalty for a wrong answer. So it is to your advantage to answer all of the questions. All right, exam strategies. You want to read each question slowly. For instance, there was a question that Angela asked, and the very last of the question, the very last word was accept. You know, really think about each word intentionally of what the question is asking you. What is the first thing you do? That's how you think about the test. Sometimes there is 2 things you would do, but what is the very first thing you would do? Eliminate obvious wrong answers and watch out for negative stem questions, such as the question that will say, all of these things are except, right? Remember, again, this is an international exam. So if you go blank, guess, breathe, and then move on. You can always flag the question and go back to it if you have time, but do answer it. Exam strategies. You want to work at a comfortable pace, knowing that this is a time exam. Mark any questions you'd like to review. That's what I mean by flag it. Make your best choice and review if time goes on. Next slide, please. All right. So really think about when you're answering answering questions, that rely on your first impression. The first answer that pops in your mind is usually the correct answer. Don't change your answers unless you are absolutely sure that you've chosen the wrong one. It may be counterproductive to review answers and make changes, especially if you're struggling to get through the test. So you definitely really do want to pace yourself. Once you get done, there is always, like if you have time left, there's always the second guess. I want to go back. Like I said, only go back if you think you need to. You're absolutely sure. Sometimes you're like, I can't wait till this test is over. Then you're at the last question and you don't want to submit your test because it's done. It's done. And it's done in a way that some folks are like, yep, I just lit that up. I'm done. Some folks is just like, okay, it's done. I'm going to be worried about this until the test results come out. Whatever your done is, just know that you're done. You've done your best, and remember your why. And good luck. Hit submit, it's over. Waiting for your results can sometimes be daunting. Know that, understandably, I understand. Constant thinking about the exam, constantly, that will eventually fade away, but you don't want to obsess about it. Try not to be obsessive where you're checking the website every single day. Remind yourself you did the best. But in the meantime, what you can do is stay connected to your professional community. Keep learning. Act as though, yeah, I passed the exam. I need to, keep my professional development moving. I need to be learning the latest resources, the latest research. So just keep moving and waiting for those exams. That'll really lessen the amount of time you have to really obsess about it. And remember your why, always. It always goes back to what is your passion, and let that be your guidance on all next steps after you pass the exam.
Perfect. Thank you, Sekeita. By the way, someone has commented in the question box, Sekeita, I would listen to a podcast of you guiding me in confidence. I love your calm and confident voice. I agree. I'd love to have Sekeita, somehow, some way sit next to me. Okay, that's great. So you referred to HIV. And so let's touch on HIV. And I actually pulled out, so I have all of my books sitting next to me, but the one that I pulled, you pulled the same. See, there you go. Okay. And basically the summary of HIV is that it really is country specific because it has to do with the availability of ART, the antiretroviral treatments. And so indeed, if the parent has the ARTs and the infant is receiving them as well, that reduces the transmission. And so to your question of, is mixed feeding okay? It could be depending upon the country. And so if there is a question about that, then that's one thing you want to note is whether or not it's a high resource country, a low resource country, etc., in order to determine what the answer could be. Okay, so there's that piece. Also, I'm going to pause my screen sharing for a minute because someone asked for the reference from the World Health Organization on vitamin D. So I'm going to grab that in just a moment. But then somebody else asked for the risks, a couple of people asked about the risks of skin to skin. And so I do want to point out that this is the supervision and SUPC or sudden unexpected postnatal collapse. And here we're looking at, let's see, infants appear to be at the highest risk during the first 2 hours of life while in a prone position and unsupervised. Therefore, one of the recommendations is to ensure that we've got supervision, as I mentioned, positional changes of the infant, as well as someone checking in on the parent and on the infant while the infant is skin to skin, to ensure that the parent is able to keep the baby skin to skin and in a safe position, that the parent is supported and that they're not simply left alone with the infant in a skin to skin position. So the suggestions, there are 10 steps. They also recommend routine oxygen monitoring. And there we go. Okay, so it's the observation as well. So there you go. And I'm going to grab that. I'm going to grab that link. So give me just 1 second. And I'll grab the link about vitamin D. Go ahead, Sekeita.
Yeah, I just placed a couple links in there that I was referring to regarding IBLCE, live remote proctoring checklist, and also the Prometric.com, the COVID-19 updates. Those are 2 websites that I suggest, even up to the day before, just checking to make sure that you know what you know about what is expected, whether or not you're doing the live proctoring or whether or not you're doing Prometric. And I just do want to say this, that when I said that I know someone who's had their tests, I know a couple people who've had it automatically disqualified due to those reasons. And so please don't take that lightly. And it's unfortunate because that can really be heartbreaking. And it really truly was heartbreaking for a couple people.
It was. I will say that there was a glitch with the exam in that first year of COVID. you know, like right after when remote proctoring was just what exploded. And so just to be mindful of the fact that, you know, there was, when that issue occurred, here we go. We've got the vitamin D reference here that I'm putting into the chat. There we go. And so do be mindful that IBLCE was aware of it, that people were able to reach out to IBLCE and let them know that there was a problem and that there was an issue. So just FYI. Okay, there was something else. Somebody else asked a question about developmental milestones. How do you memorize all of them? And I think the goal there is to, and in our preparation, how to create a study plan webinar, we actually talk about the different resources that you have. And actually that one is still available. It's on our website, and it's also available on YouTube. If you want the handout that went along with that, which has a lot of URLs for how to study, where to study and such, you can actually go to our website and find it. It's creating a study plan. And so I am looking.
I want to say something about that. That's a great question, by the way. And I like that question was asked, because when I resat for my exam, I was working in the hospital, so used to the little bitty ones, which was my primary focus. Now, I still saw clients outside, but not nearly as many small babies. And so knowing that, yeah, know that stuff, because I had to brush up on it. Yeah.
Well, that's it.
Totally appreciate that question.
You do need to brush. Yeah, exactly. And the CDC website is basically, you know, quickly, the CDC website is actually something which is great to review. They actually have, in the United States, they actually have a whole list of different developmental milestones and what to do. And they have resources for parents as well. And so take a look at those resources for parents and see what may be helpful. Okay, milestones, vitamin D. Oh, somebody asked about questions. You know, how are questions scored, or how are they removed? So indeed, so this exam, one of the reasons why, and there's a whole blog post about it on LER's website. Why does it take so long to get my answers? And so one of the reasons why it takes so long is because each question is actually reviewed to determine whether or not it performed in the way that it was expected to perform. And so there's actually a psychometrician who reviews that content and actually checks the data for each one of these questions. And the nice thing about it is that in the checking of that data, for example, let's say that there's a question which performed well in every country except for one. Well, then they're going to take a look and find out why. Why did that question not perform as well? Did it have something to do with the translation of the question, or did it have something to do with the actual practice in that country? And indeed, if it has to do with practice, then that question will be thrown out and the exam will be rescored. And in that example, logically, it would be that only the people in that country would have their exam, have that question removed and their exam rescored. But it could be that it's something which, if psychometrically the item doesn't perform well, then that question could be removed for everyone. And so just want to point out the fact that they do actually an analysis of every single question, and that's one of the reasons why it takes a long time to get your results. For most of you who are going to be utilizing computer-based testing, either at a testing center or live remote proctoring, understand that not everyone in the world has access to that, to those resources. And that's another reason why the exam may take a while, because there are a few far-flung locations where it may be paper and pencil. And so in those situations, we actually have to receive that from those other countries in order to determine whether or not, receive that and then score it along with everything else. So just a couple of reasons why it takes so long to actually get your results. Okay, Sekeita, anything else that we need to cover? Miss anything else?
No, I just want to give a kudos to the participants who joined. Their questions, I mean, they kept them coming. So this is one of the most engaging groups that we've had. And so I just thank you for your questions. If you have additional questions, feel free to reach out.
Absolutely. Please do reach out to us. Let's see, how long does it take to to get the results of the exam, several weeks, if not, I should say a few months. Reviewing pictures, we've got flashcards. Also, Breastfeeding Atlas is good. The CDC milestones. Someone just mentioned, though, that the CDC milestones page is down due to new updates. I wasn't aware of that, so I'll double check that. But do indeed, you know, any country and any time that they show developmental milestones, I think that's something which is helpful. I think that's it for now. So thank you both very, very much. And by the way, oh, just one quick thing, that book I showed you, Breastfeeding, A Guide for the Medical Profession, that's not necessarily something that we recommend and that you need to go out and buy, okay? Utilize the resources that you have and go through them and find the areas at this stage of the game, find the areas where you don't feel so comfortable and confident. Find those areas, and that's what you study. If you work in a hospital setting and you see newborns all the time, you may not necessarily need to review that, but you may need to review nursing a toddler. And if you are working in the community and you often see these nursing older babies, then you may need to review what happens in a NICU. And so by all means, do study the areas where you have the best opportunity for growth. And thank you.
And continue growing forever and ever and ever. I'm saying that seriously. Now, you know, I can't say it enough. I can't say it enough. You know, I wish I could say I was a walking dictionary of every research and everything that's come out, but notice both Angela and I both had our books out because we really value getting the correct information to you. And so that means that we'll be lifelong students, which is okay, because remember, we have the passion for this, so good.
That's true. Thanks everybody for joining us today.
Yeah, thank you. Have a good rest of your day or night.
And good luck.
Yes.
Good luck.
Good luck and best wishes. Bye.
Bye-bye.